Well, welcome to everyone who's joining us here on Monday for our Ovadia Heart Health live stream. Very excited to be welcome here with Peter Cummings. Hello, Peter. Nice
Hello,
to see
Krisna.
you.
How are you? Nice to see you again.
Very great. Before we launch into all kinds of exciting things here today, do want to remind everyone who's listening or watching or both that anything we talk about here today is not intended for personal medical advice. If you're interested in working with the Ovadia Heart Health team, please reach out to us at team@ifixhearts.com, and we can talk to you about your personal medical issues. So this is an exciting week for you, Peter. We're going to jump to your book release here real soon, but there's probably a good portion of our listeners who know about your work, are familiar with the great things you've done also with Nutrition Network. But how about the Cliff Notes version of your background, where you are, and what's kind of lighting your fire these days?
Yeah, 35 years of operating in this space with exercise and lifestyle as treatment. I have been self-employed since 1993 and working in a cash-based model to try and develop services that help people, upstream as much as possible, and to try and guide them towards, the actions that they need to restore their health, or at least maintain it if they're in good health. And that's led me through 3 medical fitness centers that I've developed, director of cardiac rehabilitation for 10 years approximately, certifications with the Nutrition Network as a medical practitioner and metabolic health practitioner with the Society of Metabolic Health Practitioners, lecturing with the Nutrition Network, mentoring people through the medical certification program, and now the coaches certification program with the Nutrition Network. So yeah, I'm giving back and trying to grow the knowledge base within the community of people that are trying to do the same thing.
Very exciting. That's a lot of hours of work, and I'm sure a lot of our listeners who, tuning in to hear either Dr. Ovadia as a heart surgeon, you've got a lot of connections in your background with cardiology, rehab, and what would you say, Peter, are some of the, sort of struggles you saw that motivated you into your work, but maybe some of the struggles you're seeing consistently still within that realm? And that's a huge broad realm of cardiology here, but I know our listeners are interested in that area.
Well, underlying it all, metabolic health is a major driver of cardiovascular disease, and that's led me to the book, which is basically documentation of the framework and architecture, the mindset that I use, the algorithms that I use to go through, and much like they would in medical practice, but with different endpoints, rather than a diagnosis with a pharmaceutical or a procedure. I'm trying to figure out what is the best advice to give to the person that's in front of me based on the domains that I practice in, which are exercise, nutrition, sleep, stress, relationships, things like that. And I think the disappointing part for me on my journey, and it continues now, and hopefully at least the book will bring me some some closure, I guess, is the fact that the trajectories that I see people go through towards illness are highly predictable. If you were to ask the regular practitioner, do you normally see triglycerides to HDL ratios climbing, and fasting glucose climbing, and gradual weight gain, and blood pressures creeping up, and eventually myocardial infarcts and diabetes diagnosis? Anybody that's practiced for any length of time would say that's very familiar, that's predictable. But there's nothing within the usual care system to address that. It's the wait and see game. right, like the usual care system waits to see these things happen until it's time for them to step in. And medicine is almost forced in its current format to step in on the last step, the diagnosis, the procedures, that type of stuff, where I've always wanted to step in way back. And I think the work that I've been able to do, the publications in the American Journal of Preventive Medicine and others, have shown that as predictable as the decline is, the reversal is also just as predictable when you're doing the right things. And that's where I focused. And it's so great to see doctors like Dr. Ovadia developing models that were similar to the one I helped develop in Buffalo back in 2011, which involves people like yourself. Something I call in my book, health investment worker, right? Someone who's working with individuals to try and build their personal health wealth. And because we don't have the level of licensure and we don't have the cost associated with speaking with us as we would, a cardiology surgeon, we can do it more often, and we can help people on a day-to-day basis to remodel their life. And it's people like us and health coaches are a critical part of this new model.
Just for our listeners, I did not pay Peter to say that, but I do, just as a disclosure there, that very, let's say, heartwarming to hear that. And, Dr. Ovadia talks about this a lot. We work in in a team-based model. And I'm going to steal this new term from you, health investment worker, because it does take a team. And
absolutely.
If anyone is interested in finding out more about how we work, especially in the employer wellness programs, the link is up here, ovadiahearthealth.com/wellness. And Dr. Ovadia has often said, because our plan is first you meet with the coach several times, then you meet with the nurse practitioner, and then you get to meet with him, that we've solved many of the issues before they even get to have that visit with him. And I know you've worked in team-based models. You've got a lot of training in the fitness. What we're talking about here is really a new system. And I know I'd written that word down because Dr. Ovadia talks about health as a system in his book. And now you've got a new book. So to give us a little bit more on that, what are we talking about here?
Health ballistics. It's out on Wednesday. It's available on ebook right now, both on Amazon. The paperback's out on Wednesday, but I call it a healthcare architecture. It's a new architecture, and it uses health investment workers. One of the doctors that I was able to intern when I was developing medical fitness model here in Buffalo for Buffalo Cardiology and Pulmonary Associates was Dr. Paul Washburn. And I write about him in the book. He wrote a paper because what he did was he followed me around and tried to document what it was that I had developed with Buffalo Cardiology. And it's exactly as you described. It's a team-based model. We had a physician's assistant, just in case we needed to prescribe, deprescribe, order labs. We had a nurse that was trained in low carb to do with nutrition. And I had a team of exercise physiologists that I trained as health coaches. And so we had similar components, and this was back in 2011. And I basically had to recreate a system similar to what I saw in healthcare. And a lot of it is modeled off of cardiac rehabilitation, which I'm sure Dr. Ovadia is very familiar with. But cardiac rehabilitation is really one of the first and only lifestyle modification programs that is reimbursed in the usual care system. When you look at cardiac rehab, it's for a specific population, but individual treatment plans, and that's something that we use in this model. So we're reevaluating patients and replanning every 30 days. We're looking at labs, we're looking at habits, we're looking at biomarkers, and we are sending that out to the patient's providers, so everyone's on the same page. And that's the model I continue to operate with today. And I think what we've done is we've taken what often was what I call in the book a 5-word treatment plan. You need to eat better and move more, or you need to eat better and exercise, which anyone would recognize is not a treatment plan, and took that placeholder, moved it out of the way, and said, this is what goes in there. And that's what this is the model that you're working on there, and the one I've developed and write about in the book.
And just on the wordplay, but when I hear the word ballistics, I think of athletes, of course, that require. I had a long career as a professional dancer, and ballistics is part of the training in a different way than an athlete. What is the ballistics component of the book?
It's about trajectories. So it's about looking at what I was describing earlier is the slight rise in glucose over time, right? In typical labs, it's red light, green light, right? You're still good, you're still good, you're still good. But, people that are trained like you and I and Dr. Ovadia and others would realize, oh, wait a minute, this person used to be in the 70s, then they were in the 80s, and now they're at 98. Well, 100 is the cutoff for what we would consider normal. But even then, a lot of times these numbers are ignored because there's no treatment for someone with a fasting glucose of 105. So prediabetes often goes undiagnosed, it goes untreated. And the ballistics part is about altering the trajectory of these very commonly seen metabolic disturbances. The weight gain, the hypertension, the triglyceride HDL rise that we see, which I'm describing the metabolic syndrome, if your listeners aren't familiar with that. But this is one of the major drivers of cardiovascular disease, if not the major driver, when you really look at the numbers. There's not too many people that end up in a cath lab that don't have a high level of insulin resistance or hyperglycemia. This is what the data shows us.
And in fact, still, many people will not even get a fasting insulin number on a standard lab panel. That's still considered, sort of unusual unless you're working with someone specialized like you.
Well, that's what I do a lot of is educate, again, the patient. The person in front of me has come to me probably because they've heard about me, but they want to do something for themselves. They're not happy with the answers that they get. They're not happy with hearing for the 5th time, you need to eat better and move more, because they don't know what that means. They already assume that they were eating well. And I teach them about insulin resistance. I teach them, your numbers say that you should have had a C-peptide. You should have fasting insulin. And then from there, we know it works. I've got the documentation that it works. We just work on the things that change the numbers. And I've got over 1,000 patients that I can show you these trajectories changing. So the ballistics came from Paul Washburn, who was that intern who published the paper on the model. And what he called it was health ballistics, a multi-reference point informed probability theory.
Oh, wow. Okay. I'm not sure I can repeat that back to you, but
don't try it. I can't believe I tried it, but and Paul became a very good friend and in a way a mentor, because he was involved in a lot of the remote model care of my patients. So when I needed a like-minded physician, he was licensed in New York, even though he was out in Wyoming. He would see the patients remotely, and he helped with that paper there, which is the rapid remission of type 2 diabetes and hypertension on a 70-year-old male. And that's so I've named the book in honor of Paul's paper, Health Ballistics.
Fantastic. And Well, just for our listeners, you said it's available in ebook. If they go to your website, plantopeak.com,
No,
or
I
where?
got to get it on Amazon. I haven't set up
Okay.
any links yet. Yeah.
Okay. So it's on
Ebook's
there.
available today. In fact, I just took care of the X-rays, so all the glossary of terms has definitions in it now, and the paperback will be available Wednesday on Amazon, the 4th.
Fantastic. I'm very excited. I see some interesting reading on my horizon here. You've mentioned tools a couple times, and accessibility. What does that mean in a practicality? Because part of what we try to do here on Monday is really give people actionable things, not
Yeah.
just talk theory. And I know through Nutrition Network, you've always been really great on
Yeah.
talking about the tools that you give people. Elaborate a little bit on that for us.
I think that's. I normally don't wear white. You probably have never seen me in white, right? I used to say I was the guy that was willing to get dirty. That's why I wore black, So I'm wearing black for that. In part that reason, I just don't like getting dirty either. So you can't see it with the black, right? But it's about application. All this is great to talk about, but the bottom line is when you get done talking to someone and they get motivated, they want to know what to do, and it's about application. And really, that's the whole point of the book is how to apply these things. In fact, I've built free AI agents to help people assess their metabolic syndrome severity score, their cardiorespiratory fitness level, and what would be appropriate as far as training volume, to evaluate their nutrition, a self-check on nutrition. It asks question like, are you protein forward with your mentality? Are you avoiding processed foods, your sugar sweetened beverage, your alcohol, all those things, and then sleep and stress. So I've got a bunch of free agents that kick out population, eat better, a little bit better than eat better and exercise more, but more specific than that. But it will help them navigate through the book so that they can actually create, and just like we're talking about, the key part of the book is what I've called the weighted variable matrix. And that is how I process all that information. So if, let's say, instead of the AI agents, I took all that information in, and you're probably thinking like this too, is what's the most important thing I could tell this person? So for example, I had a type 2 diabetic, female. She was approaching 300 pounds. I assessed her cardiorespiratory fitness is very poor. But in conversation about her sleep habits, she was sleeping 4 hours a night. So I would love to prioritize improving her fitness, but I know that sleep allows for recovery. So if I were to start to stress her before I improve her fitness, I'm doing her a wrong, because nothing good comes from that. So I coached her on nutrition, and within a week, she was getting an hour more sleep per night. And, for anyone that sleeps poorly, to get one more hour of good sleep, it really started to make a difference. And that's when you can start bringing in things like exercise. So the weighted variable matrix is a way of navigating through your assessments and then figuring out what's the most important thing for you to do now. Is it to reduce your carbohydrates and eat protein forward? Or I already do that pretty well. I need exercise. I'm not exercising. And that's what the book is about, is how to make it actionable. And I wrote it for 3 audiences: the individual, people like you and I that don't have a Dr. Ovadia, right?
Right.
Is how do you build a team? How do I practice like health ballistics talks, right? So it's for the provider. So this is how I look at blood work and biometrics. And then lastly, the employer is how do I curb unnecessarily utilization? And that's what I'm big about, is that, there's a lot of people out there trying to discount pharmaceuticals and treatments and get better pricing on stuff. And I always think the best price on unnecessary treatment is to not have to pay for it at all. And I think the self-funded audience kind of gets that since it's coming out of their checkbooks all the time. And I don't think many employers have any idea of how much utilization could be curbed. Like I just mentioned, prediabetes. Most people don't know that 90% of prediabetics, 90% of all prediabetics don't know they're prediabetic. Yet the rate of progression to type 2 diabetes is 11% a year. So that basically in 7 years, all pre-diabetics are going to be type 2 diabetics. Yet everyone acts surprised when there's a diagnosis of type 2 diabetes, which increases the cost somewhere, depending on which market you're in, somewhere between $13,000 and $19,000 per head. Cardiac rehab is another example. I mentioned cardiac rehab. The national referral rate to cardiac rehab, last I checked, was 35%. Cardiac rehab is a class 1A recommendation. Why? Because it stops second events and it stops hospitalization and it reduces death. I would think that if I'm the guy paying for all this healthcare and I just paid for the stents and I just paid for a cabbage, I think I would want to make sure that all of those patients made it to cardiac rehabilitation. But many employers, they're trying to do whatever they do, and healthcare is something that's been legislated down their throat, and they are just trying to make do, and they trust discounters rather than someone who's going to change the model completely.
And so many important points here so just to be clear on that, so 90% of pre-diabetics
have no idea they're pre-diabetic. No one's told them.
That's an astonishing figure, but yet when I think about it, worked with many clients, patients, both
right.
in our medical practice, and no one ever even talked to them about, oh, your numbers are good, right? Your fasting glucose was good today. You're good.
I got a classic. I got a guy who came in because his wife forced him to, because she had done so well. She dragged him in. So I'm looking at his blood work and I'm like, so do you know that you're pre-diabetic? And he said, no, I'm not pre-diabetic. And I'm like, well, the odds that you're not are pretty slim. And he says, well, what do you mean? I just saw my doctor last month. I'm like, yeah, but your fasting glucose is 109. And I show him, it's his blood work. He brought in the paper, right? So on white paper with gray font, I asked him to read the part underneath with a number. And it said, well, it said I should have gotten further testing. I'm like, yeah, that thing's called the hemoglobin A1C. But my guess is it's going to come back at that fasting level. You're probably going to be 5'8", maybe 5'9", but you should have been further tested. But you're more than likely pre-diabetic. Plus, he was already insulin resistant. All the other markers were there. So it was and sure enough, he was when they got the test done. And this, I can't tell you how many times it's happened in my career that, I identify these things and ask the patient if anyone's talked to them, and they weren't. So my experience aligns with that publication. I can't remember. I'll get it to you if you want to put a link to it, but it's out there. I think it was the American Physicians who published that.
And this is a classic example of what you just gave of the wait and see.
Yeah. Because the algorithm says do not give them metformin until they're at 6.0. Right? That they wouldn't prescribe metformin until you're at 6.0, which is pre-diabetic. Diabetics at 6.5. But at 5'7", 5'8", and 5'9", I guess I call that the ostrich treatment plan. You stick your head in the sand and look the other way. But it's at that point, then you and I could be stepping in, and our teams could be stepping in and making sure that this does not progress to type 2. In fact, that first paper that I published, we had 131 pre-diabetics, some of which we followed for almost 6 years. I think the average was 18 months. And out of that 131, only 2 progressed to type 2 diabetes. So that's a progression rate of 1.69%, where I mentioned earlier, the progression rate is 11% in that population. So that is a major cost savings. If employers are seeing their diabetes costs continue to rise, it's not just the medications. It's you have more diabetics. And that, what I just highlight, is a major reason.
Phenomenal. And this is such great information. If you're interested in getting more specifics about what Peter's doing, check out his website, Plan to Peak. And the number 2 is in there if you're just listening and not watching. And very exciting about his new book, Health Ballistics, coming out Wednesday this week. I see we have a listener here on Meet Reset Go, Louise. I'm so privileged to be in the NMP class of 2026. Congratulations. Can't wait for your lectures in the coming weeks. We'll be getting your book too. Yeah. Nutrition Network is doing some fabulous things. They're very lucky to have Peter on his on their staff. Congratulations to you, Louise. And can we dive in a little bit more on this employer side? So this was just some great information about, the trajectory of, you're not just in the safe zone if you're pre-diabetic, not only on the costs of medications, but what would be some major, not major, what are some of the low-hanging fruit that employers are totally missing out on?
Well, as I mentioned, I have a free agent called the Metabolic Syndrome Severity Score. Now, as you probably know and remember, the metabolic syndrome are 5 different markers. If you have 3 of the 5, you can be diagnosed with metabolic syndrome. And this is never done in usual care, despite that it's a legitimate diagnosis. I think it's E8801 or something like that. But it's not noticed. It's not noted in medical records because there's no treatment for metabolic syndrome. What they do is they treat these symptoms separately. So hypertension is one of the first ones that appear, and weight gain. Well, they never had anything for weight gain other than stimulants, but now they got the GLP-1s. So you get ACE inhibitors and GLP-1s, right? Then you got triglycerides and HDL, triglycerides being too high, HDL being too low. They really don't have anything for that unless your trigs get really high, and then they may give you a phenofibrate. And then the last one is abnormal glucose. So that's when the metformin comes out, and then all the diabetes medications. So all these things are treated downstream when they've already gotten really bad. The thing I love about the Metabolic Syndrome Severity Score, and it's a free report on my website, and this is peer reviewed. It's built off of their I think they have 40 or 50 studies on the metabolic syndrome. It's a spectrum score. So rather than saying, kind of like the person I was mentioning earlier, let's say the trigs, the cutoff for high trigs for metabolic syndrome was 150. Well, what if you're at 145? Or your HDL is, 40 for men, 50 for female. Well, what if you're a male and it's 41, right? And your glucose is 99, and you're not hypertensive, but it's not normal anymore, right? And your waistline is not 40 inches, which is the cutoff. It's 38, right? Well, you could say, well, this person has none of the markers of metabolic syndrome if you would like, but the truth of the matter is if you put those numbers in the metabolic syndrome severity score, you would see that person is teetering on high levels of insulin resistance. And at that point, the next thing that happens typically is prediabetes. Not everyone progresses to prediabetes, but if you look at the people that end up in the cath labs having MIs, getting cabbages, those people are all highly insulin resistant. They, as Dr. Ovadia mentions, the metabolic dysfunction is core to his system, and that's why it is. When you end up on his table, those markers are highly prevalent, and or the medications for those markers are highly prevalent, and they can all be moved with what we do. It's that simple, and I highlight that in the book. It's not about diagnosis. It's about what do I do about it, right? What is my personalized prioritization plan? And the agents that I have for free, and this is how employers can help anybody that they want to help. And my upper level agent is called the Health Ballistics Report. This is a personalized report. So I charge for that report, but that takes all that information in just like I do. So it's programmed from me, my mindset, to look at all of these. And then the report that comes out from the Health Ballistics Report is a comprehensive report on each and every one of your health domains, your exercise, your nutrition, and then it's prioritized with the thing that is going to give you the most bang for your buck. I call them levers. So this is the lever you should pull, and this is another one you should pull, and the other ones you're doing great. Just keep this up while you pull on these levers. And I can see it. The reason I developed it was to scale health ballistics, because my mentor, Dr. Robert Gatewood, who's the cardiologist that was in charge of that model I built in 2011, he saw that remote modeling and bringing down barriers for patients, being able to do a coaching session like this rather than leaving work or, having to drive 30 minutes was the future. And I was already doing that with my athletes. So if you're watching and you see this thing behind me, I have 12 national champions, and I've been training athletes remotely for 25 years. So he saw that what I was doing remotely and said, this is the future for patient care. This is what I want you to build. In 2011, the devices weren't available, but now I've got Oura rings, Bluetooth blood pressure cuffs, Bluetooth scales, CGMs, right? Continuous glucose monitors. All of this can be brought in real time passively by the person who just gets on their scale or wears their continuous glucose monitor. I can monitor that. I can teach them from that. I can give them feedback. And this is all as scalable, as convenient as possible to the individual, which is the only way I see employers benefiting, because they can't get into the treatment rooms. It's not allowed. They're influencing what they can, but I think ultimately the individual that walks in has to be better informed to make sure that they're getting the best of care for the money that the employer is spending and the money that we're all spending now. I think that's one of the most interesting things that's happened to me over my course of my life is my fees are now much more tolerable, because everyone is used to paying through the nose for deductibles and copays. Yeah, now paying for someone to actually help them to get healthy less than what my copays are is highly interesting all of a sudden, where 15 years ago when I was doing the same thing, to charge anybody for anything, if it wasn't covered, right? Is it covered? They would bring out their card, like, no, your insurance company doesn't want anything to do with me.
And that, well, this is an interesting place to be, right?
Huh?
That people are waking up to what we started this conversation talking about health investment, and it really does take, there is some money involved on that, but if you're really truly wanting health, you're going to have to sometimes think outside of what is in your health insurance plan. Right?
Things are changing though. I've been using remote therapeutic monitoring and remote physiologic monitoring, which are both lifestyle coding now. So I have contracted with some physicians to take care of that part of their care. And then I just provide them with the billing codes. But remote physiologic monitoring and CCM, or chronic disease management.
Fantastic. Right.
There's codes available now, and I think Medicare is liking what they're seeing, and they're actually bringing out more codes. So I think in the near future, things are starting to slowly change.
Right. Let's hope so. I want to go to one terminology. We've had a lot of different exercise physiologists, from Dr. Ben to Doug McGough to Phil Moffatoni. How would you define and help our listeners understand, what do you mean by cardio fitness?
Well, I think one of the most interesting things about that metric is it's ignored in healthcare, yet it's a fantastic predictor of mortality. So if you look at JAMA and the Journal of American College of Cardiology, the two of them tracked over 1 million patients and stratified them or classified them by cardiorespiratory fitness. And those with the highest level of cardiorespiratory fitness outlive the people with the lowest cardiorespiratory fitness 400%. So why is that? Well, what is cardiorespiratory fitness? It's really a global measurement, right? When you think about what goes into that, well, you have to have a good, strong heart, and you have to have good functioning pulmonary system, the lungs. You have to have good perfusion, your arterial system, your vascular system. You have to have active muscle tissue to absorb the oxygen. So there's so much involved in that measurement. It's a global measurement of function. So cardiorespiratory fitness is taking into account so many different systems and function. And I think the other thing that comes with that is with high function comes higher quality of life, right? So I talk in METs because I think ultimately after I explain it, it's so much easier for people to understand how activity and exercise fits into our life. So you and I are at one MET, okay? And what a MET is 3.5 milliliters per kilogram per minute. That's how much oxygen you and I are using right now. I'm probably using a little more because I'm talking. Right?
Yeah,
okay.
maybe.
But when you get dressed, self-care, like shower, things like that, your oxygen needs start to increase. And that moves you up to 2.5 METs. And then when you walk, it's 3 METs. And when you walk briskly, it's 3.5 METs. And when you push a lawnmower, it's 5 METs. So the more intense you get, the more oxygen you need. And physiologists quantify that so that we can make equivalents with multiple different things throughout your life. Because not everybody wants to ride a bike like I do. I love riding my bike, right? Not everybody wants to run or ruck. But if you take all of these into totality and then explain the system to someone so that they can build their own active lifestyle that meets their current cardiorespiratory fitness level, because the cardiorespiratory fitness level determines their physiologic capacity and margin to handle physiologic stress, right? So, this 10,000 step thing, it drives me nuts because I've worked with people that cannot finish a 6-minute walk test without resting. So the way that test goes is I need you to walk as far as you can for 6 minutes, and they need a chair within 2 minutes. So these people, what's more appropriate for them is about 2,000 steps. So you give them 10,000 steps as a goal, you're providing them what could be considered a toxic dose of physical activity. So by understanding that, and then understanding that about 5.5 METs, if you can't max that, like if you can't mow your lawn, for 30 minutes, you are probably functionally dependent on others to do things like cut your lawn, like shovel, like get your groceries, like help you, right? So cardiorespiratory fitness is not only just about physiology of what's going on in your body, but it also represents what you're capable of doing in your life. I remember one woman I started early at Buffalo Cardiology. She didn't want to hear about fitness or her blood markers or getting off meds. None of that had anything. She wanted to water her flowers. She wasn't strong enough anymore to water the flowers. She couldn't hold and that was her motivator. And as a coach, that's what you go after then. Okay, we're going to water some flowers this spring, right? She didn't want to hear about her A1C, didn't want to hear about any of that stuff. I knew we could move them. I knew we could make those better, but that was what was important to her. And quality of life is important. And cardiorespiratory fitness ties in so much. When you think about it from that MET perspective, right? Going for a walk with your grandchildren, okay, well, there's a MET level for that. Some people can't do it, not for very long because of their cardiorespiratory fitness.
Excellent. And for those of you who don't know what a MET is, that's a metabolic equivalent of task. Yep. And you can look that up and find it. But this is wonderful information here. Do you talk about with your individuals about the difference between getting some metabolic, some MET activity during the day and their structured exercise?
Yeah.
We try to highlight the difference between that because we'll have, I think it's Neville Owen, exercise physiologist from Australia, talked about prolongers and breakers, people who break up that sitting time with some kind of higher MET level.
Yeah, and it doesn't take much, just get up, stop being sedentary. That's one of my challenges here in my comfortable office is realizing, wow, I've been sitting for 2 hours straight, right? getting up and doing some of my functional exercises, some stretching, some moving, going up and down some stairs to get some more water or whatever. It's important to break up sedentary time periods. But back to the metabolic equivalent of task, there's ways of getting a lot of activity in your life if you actually take some time to think about it. Okay, my fitness level isn't great. As this guy on the live stream says, I'd probably benefit if it was better. Well, if you run the report on my website, it'll tell you how many METs you need per week, right? And then, as you just said, you can Google MET level for any activity you want, and you'll find it in the search. And I have 2-page list in my book of so many different activities, and you can structure your own activity/exercise plan. So if it says that you're supposed to be between 10 and 15 MET hours a week, so a MET hour would be, okay, if you're walking for an hour at 3.5 METs, you've earned 3.5 MET hours, right? So let's say you don't want to walk for an hour straight, you do 3 20-minutes, that's still 1 hour, right? So that's 3.5 MET hours. And if your goal is 10 to 15 for the week, you need to find a little bit more time to walk, or maybe mow your lawn, like I mentioned, at 5 METs for a half hour, or whatever you'd like to do. It does not have to be structured exercise. Although structured exercise also helps, especially, as you probably know, resistance training.
Resistance training, yes, we're very big on that. And what would be some of the reasons, just for those who maybe are not as, let's say, big proponents of resistance training, how are you helping your individuals on this individualized program in that realm?
Well, I'm very big on Gray Cook and Lee Burton's functional movement system, right? So as I built that second of 3 medical fitness centers, I was working for Buffalo Cardiology, and one of the first tenets of healthcare is first do no harm, right? So I had to put a program together that showed that we were assessing people before we prescribe anything. And when it comes to loading someone with weight, even body weight, you should be assessing their movement competency to ensure at least a minimal level of competency before you load them. Because if you have a dysfunctional movement pattern, like let's say you have someone with really bad shoulder mobility, right? So my shoulder screen, right, is to take your right and left arm and see if you can't get them behind yourself, right? Okay, that's great. So shoulder mobility, congratulations, right?
On one side, not so great on the other side. Well,
right. So that's an asymmetry, right? So that's an asymmetry. So you have some things that you could do, because asymmetries and dysfunction, right, are predictors of risk, right? So you may need to be a little bit more careful when you're loading overhead, when you're lifting things overhead, because of that asymmetry. And if you screen someone, okay, well, I can do a lot of these exercises, but those right there, I describe them in the book as red lights. You should not be doing those until you correct that movement.
Dysfunction.
Yeah. And then you need to you don't need to be optimal, but you need to be at least, at a level where you're not dysfunctional. And then you just modify the exercises a little bit, and you'll get the benefit that you need from resistance work. And I think it's quite profound. I mentioned in insulin resistance, the flip side of that is insulin sensitivity. Well, the more muscle you have and the more you activate your muscle, the more sensitive that muscle is to not only insulin, but it will pull glucose in without insulin. So it's non-glucose dependent glucose uptake. And then the other thing, and I think I heard it was Tommy Wood say this, he called it a glucose sink or reservoir. Right? So the more muscle you have, the more place you have to put glucose. So, when you have a little bit too much, you got some place to put it before your liver has to do something with it.
And, I really appreciate you highlighting this thing about functional movement, because so much of, let's say, the nation's life is very sedentary, and we can go, there's all kinds of influencers out there saying you need to lift big, heavy things, and, got to have a VO2 max of this range. but you need to be able to move functionally, to be, especially in my age group, to age with some kind of independence.
Yeah.
And sometimes we lose sight of that functional movement piece.
And that's what the architecture really highlights is all these things, right? Do you need to eat better? Well, what is eat better, right? and then look at those habits and highlight, okay, these are the habits that make up eating well. And these are a couple that you're not doing as well as you could. If you could focus on those, that would be better. And the same thing for exercise. Your cardiorespiratory fitness ranks as fair. And the higher it is, the better your mortality risk. Well, right now, this is the level of activity that's appropriate for that level of fitness. And if you're going to do resistance training, like you should screen yourself to make sure that the exercises that you're considering are exercises that aren't going to hurt you. Nothing's worse than someone who's motivated to get started that all of a sudden gets hurt because you prescribed it incorrectly. So the system is set up to help people navigate all these different issues through self-assessments, self-checks, and then a prioritization of what should I do.
Fabulous. Well, as we get close to kind of our closing minutes here, are there any topics that you really wanted to hit on that we didn't touch here, Peter?
Let me check my my notes here. Well, I guess two things. One, to the employer, if someone is trying to bend this cost curve, I highly suggest you look for unnecessary utilization. Find someone that can help with prediabetes. Look at your claims data. As I mentioned in the book, if certain claims appear and then others don't, you're maybe not be getting the best care for your people. And cardiac rehab is a perfect example. If you see the codes for stenting and CABG, yet you don't see the codes for cardiac rehabilitation, right? You know that,
right?
You're a class 1A recommendation that stops second events, stops rehospitalizations, and stops mortality, right? This is peer reviewed. This isn't a publication. It's a class 1A. There's no higher recommendation. Why are my people not getting that? And that's where you have to put pressure on the system, or educate your people at least, so that if they are one of those people that needs that treatment, if they end up on Dr. Ovadia's table, right, that they're getting cardiac rehabilitation. But I have a whole couple chapters on all the different codes they can look at in health ballistics. And I guess the other thing is I really hope that some providers pick this up and pick up a few things. I know the doctors that I've given it to the pre-release reviewers, all of them already see things differently in their practice. They're looking for things, as I described, from a metabolic health standpoint, that they weren't looking at before they read the book. So if there's providers out there that are considering it, even if you're a health coach or a dietitian, I would recommend it. But then I guess I really hope that more providers are gravitating towards this space to try and figure out how not to be a part of a broken system, but change the system that they're in, or recreate one like Dr. Ovadia has, and Dr. Gatewood, my mentor, that helped us to develop this model and help thousands of people.
We did an absolutely fabulous work. If you're listening in here, go to Peter's website, plan2peak.com. Check out his book, which is going to be released on Wednesday, Health Ballistics. Can you show it to us one more time for those who are watching? And I'm very excited about that. And if you have the opportunity and doing any of the Nutrition Network courses, he's a fabulous faculty member there. And if you'd like to know more about what we're doing at Ovadia Heart Health, we've got several case studies from our employee wellness programs. We also have white papers available, 7 of them now, that we've put out that are all free download. And then you've mentioned, your metabolic severity score, some great tools that both the employers and employee can access. And if you're working for a company and your employer wellness program isn't, let's say, really providing good education and empowerment, start, talking, start encouraging, maybe get some links to your HR department. The more people talk about these issues, the more we're going to change the system.
I think, if anything, these reports that I provide are quick checks to see if your wellness programs are wellnessing.
There you go. Yeah.
Right. If you're not moving the metabolic syndrome severity score in your population, you probably aren't making a big difference in your cost.
That is like the simplest thing you can do. Exactly. So we're trying to, cut those unnecessary utilization costs. See how many of your people score well or don't score well, right?
Yeah.
Well, once again, you can reach out to Peter at plantopeak.com. Thank you so much for coming on our Monday live stream, and good luck with the book launch.
Thank you.
Thanks
for having me. I really appreciate the time to talk to your audience.
Absolutely. Thanks again.
All righty.